Complex regional pain syndrome, or CRPS, presents with immediate, severe physical symptoms. Patients experience rapid onset erythema, visible redness spreading, along with severe edema, or swelling. This swelling is accompanied by an intense, persistent pain cascade. The patient experiences severe sensory and motor disturbances that completely disrupt daily limb function. The root cause of these symptoms is a series of maladaptive neuroplastic changes. The nervous system rewires itself improperly, affecting both the central and peripheral pathways. Because the structural pathology lies in this neural rewiring, the condition is highly refractory. Standard pharmacologic interventions and conventional conservative therapies frequently fail to provide relief. Treating the syndrome requires an intervention that bypasses the limb entirely. Physicians must directly interrupt the systemic nervous system feedback loop at the spinal level. The cornerstone neuromodulatory intervention for refractory CRPS is spinal cord stimulation. The baseline mechanic involves surgically implanting a device that delivers targeted electrical impulses directly to the dorsal columns of the spinal cord. The clinical data supporting this neurophysiological model was extensively synthesized in a 2026 qualitative narrative review by Salib and colleagues. This Prisma flow diagram details the exact methodology the researchers used, tracing their filtering process from 126 initial records down to the 19 foundational studies included in the final qualitative synthesis. The researchers parsed these specific studies to extract recurring empirical themes regarding clinical efficacy, the exact mechanism of action, and long-term durability of the implants. The data proves spinal cord stimulation acts as an active modular therapy. It suppresses pain by modulating multiple parallel neural pathways simultaneously. Peripheral pain signals first attempt to ascend to the brain through the dorsal horn of the spinal cord. The gate control theory relies on two key pathways meeting in this area: large diameter A-beta afferent fibers and smaller nociceptive C fibers. In the baseline CRPS state, maladaptive pain signals maintain constant, rapid firing of the smaller nociceptive C fibers. The electrical impulses delivered by the stimulator are calibrated to preferentially activate the large diameter A-beta fibers. This creates a mechanical gate closing effect. The activated A-beta fibers physically inhibit the transmission from the smaller nociceptive C fibers right at the synaptic junction. The immediate clinical result is a drastic reduction in the patient's sensory experience of pain. This mechanical override forms the first layer of therapy, halting maladaptive signals before supraspinal processing centers ever receive them. Shifting focus to the cellular level reveals a second mechanism within the dorsal horn. In CRPS patients, neural synapses fire at an erratic, hyperactive rate. The central nervous system's primary inhibitory neurotransmitter is gamma-aminobutyric acid, or GABA. The electrical field generated by the stimulation drives an enhanced local release of GABA directly into the synaptic cleft. These GABA molecules bind to receptors on the receiving neuron, decreasing its excitability and forcing the hyperactive firing to smooth out into a slow, controlled rhythm. This GABAergic inhibition neutralizes the heightened dorsal horn excitability that drives the syndrome's chronic pain loop. Moving outward from the spinal cord, we evaluate the broader autonomic nervous system. The chronic pain associated with CRPS triggers severe, overactive sympathetic nervous system responses. This sympathetic overdrive causes the physical manifestations of the disease: abnormal vasomotor function, chronic swelling, and severe temperature irregularities in the affected limb. The electrical stimulation downregulates these outgoing sympathetic efferent pathways, restoring autonomic homeostasis. By achieving this sympathetic normalization, the therapy actively reverses the visible physiological deterioration of the limb. Recent engineering developments allow physicians to execute this neurophysiological model with higher precision, such as utilizing 10 kHz high-frequency stimulation. Another advancement is burst mode stimulation, which delivers grouped electrical pulses designed to mimic natural neural firing patterns. These specific modes achieve superior pain reduction without inducing paresthesia, the constant tingling sensation previously tied to traditional continuous stimulation. Parallel hardware developments now allow for dorsal root ganglion, or DRG, stimulation to target highly localized distal pain patterns. Modern neuromodulation provides a tunable, patient-specific therapy adapted precisely to individual pain phenotypes. Longitudinal clinical trials verify that patients maintain durable pain relief and functional improvement for up to 5 years post-implant. This chart contrasts the high percentage of long-term patient efficacy against the physical limitations of the therapy and approximate 30% hardware complication rate. The primary mechanical failures causing this complication rate are lead migration and lead fractures. Battery failure is the next major mechanical issue requiring surgical revision. Additionally, patients face standard surgical risks, specifically infection at the implant site, which leads to significant morbidity if not treated promptly. Physicians and patients must calculate a trade-off, balancing profound neurological benefits against the realities of implantable hardware. To mitigate these hardware risks, clinical guidelines mandate a trial stimulation phase prior to permanent surgical implantation. A successful trial requires significant quantifiable pain reduction combined with demonstrable functional improvement in the patient's daily activities. This diagram outlines the ultimate clinical reality. Neuromodulation is integrated into a comprehensive care model involving physical therapy, pharmacological management, and psychological support. Physical therapy directly capitalizes on the mechanical and biochemical pain relief provided by the stimulation, allowing the patient to safely restore their limb mobility. Spinal cord stimulation forcefully resets a maladaptive nervous system, providing the necessary physiological window for multidisciplinary care to reclaim a patient's quality of life.